All right. Thank you for calling in again this morning. We have, I think, a really strong course for you today. It's going to include discussion of PPE, sort of hands-on, from folks who are good at it and experienced with it, managing COVID-19 specifically. So that's going to be really helpful for us. And we're going to follow that with a talk by Dr. Chen on the moderate adult, the first of two lectures on treatment of COVID disease, moderate adults. So this is we'll start into the clinical stuff this morning. Dr. Chen offered to do his talk yesterday. So rather than to watch a video on the COVID testing, we'll be able to do that. I did want to start quickly by discussing what, from the outside, you know, the U.S. Pacific Islands is really a perfect storm for COVID-19, isn't it? A lot of travel, especially in February and January when we got started here, from areas where COVID-19 was already certainly circulating, both Guam and Hawaii, Japan and Korea. We have rapidly overwhelmed healthcare systems. You folks are doing so much with so little all the time that having another big influx of acute patients is a dangerous situation, especially when there are lots of ICU cases at once and requiring ventilator management. In your community, we know there's very crowded living conditions and lots of gatherings that are culturally important, especially funerals. And although you have a young population, and that's going to help reduce the mortality of this disease, the comorbidities are prevalent in many adults, most adults even over the age of 40. And we know that COVID is not nice to people who have coexistent comorbidities. A brief discussion to talk about where we are today with COVID-19. Guam has 226 confirmed cases and a big bump from last week. And these numbers, however, do not include the over 1,100 confirmed cases that occurred aboard the USS Roosevelt. CNMI has 30 cases and they've been hovering there for 15 days, which is fantastic. Fiji has 18 cases, all recovered, over 2 months with no cases. French Polynesia has 60 cases, but 50 days with no new cases. These are amazing response by the jurisdictions to manage the start of this. And so you see that if you have one case or two cases, it doesn't necessarily mean that you're going to have an outbreak on your island. If they occur in the quarantine, especially if you're on it, paying attention, strict management of those quarantines so people don't go wandering around while they're in quarantine, it can remain just a single case. New Caledonia, 21 cases, PNG 10, but 2 new ones, and everyone's worried about what's going to happen in Papua New Guinea, I mean. So with those are the places that have COVID. Of course, we have some of the few places left in the world that do not have COVID. And I think that's not only amazing, but also fortunate for those of us who are trying to help. American Samoa, Palau, FSM, and RMI. There's the Guam curve recently. And the you can see that the cases are fairly evenly split by ethnicity in Guam. And the age breakdown is fairly typical for this disease. Is there a recurrence? We're not sure, but here's an interesting thing you can do on the Apple website where they'll track mobility. And here's the mobility in Guam. We can't do this in Chuuk or, I'm sorry, or in even in CNMI. But it does tell us that people are returning back to normal activities. So some of the lockdown obviously is ending. So we have to really be on our toes and make sure that public health can respond. In the US, much of that lockdown is really quite over, other than riding on mass transit, which is still something that most people do not do. There's Saipan's cases. You have lots of tests for those of you who are going to be ordering tests for your cases. You can see here by the middle of July, there'll be over 50,000 rapid tests that have been pushed into your region. Most of these tests have not been used yet, but your labs have been trained and are ready to go with the ID Now and with the Gene Expert. You may have heard there's some questions about ID Now and is it useful? And the answer is yes, it's very useful. It seems to work better on symptomatic patients. It's not quite as sensitive as the Expert for asymptomatic patients, but still a very useful test and an important part of your testing armamentarium out in the island. So don't stop using ID Now just because you've heard that the Expert is more sensitive. The other thing I might add, practically speaking, is the ID Nows will begin to expire in September and October, whereas the Gene Experts will last for a year. So think about that as well and trying to maintain your stockpile of testing. Okay, we prioritize our tests clinically with the people that are under investigation, especially those who have symptoms. You don't need a travel history anymore. Those who have flu-like symptoms, at this point, we should be testing them for a COVID disease. Contacts are the next component of our prioritization. Then we'll start to talk about repatriated citizens and travelers. That will be a priority as they come in and they go into quarantine. I'm sorry for the healthcare workers, but you're not at the top of this list. If there's not circulating COVID disease in your community, you can use your test to do healthcare workers if you want, but typically you might just wait until the tests are getting close to expiration because frankly, they're going to be negative. If you have circulating disease in your community, that's a different story. Finally, routine community surveillance is a luxury. Saipan has done it, Guam has done some of it, Palau has done some of it, and I think it's fantastic if you have enough tests and enough time, but not a priority at this point. We have recommendations for the Abbott ID Now, and I'm happy to share that document with you. Just email me at HLD4 and I'll get that to you. And without further ado, I'd like to jump into our presentations at this point. And those presentations will begin with a discussion of our of PPE. And I haven't looked to see if Akila is on. I know we've got some of her colleagues on. Akila, are you there? Looking. Maybe having some issues with well, we'll try to sort through that, and maybe Dr. Macias, if you can, I see that you're on. Thank you for calling in. Let's see if we can.
Here now, okay?
Thank you. In the meantime, I think I'm gonna point to Chima from Guam. Chima Bakwam is one of the new folks who is actually, Chima, a couple of years now that you've been running the TB program in Guam. I'm wondering, Chima, if you could go ahead and present your slides for PPE and describe that process for us.
Doc, are you going to, good morning. Doc, are you going to share the slides I sent to you?
You want me to put those up for you?
Yes, please.
All right, no problem. There you go, boss.
Sir, okay, good morning. My name is Chima Mbakwem. I am the TB Hansen Disease Program Manager. But for the COVID-19 response, I'm actually the lead for containment and infection control. Since we started the response, we've actually trained our team on how to use PPEs because we expected a lot of testing from the community. And we couldn't have done that without the help of Dr. Tain Hancock. I can see him here. Dr. Tain has been very instrumental in helping Guam in this response. He was actually the person who trained our team for swabs. So if you look at this, this is one of the community outreaches in one of the villages on the island. These are the public health nurses getting ready to go to start the PPE, to start the swabbing. If you look behind, there's a woman wearing just a face mask, not putting on the N95. She's part of the logistics team. They stand in where we call the clean area. Their job is to support the nurses who are wearing their PPEs in the dirty area. Next slide, please. So this is the nurses. What they're doing here is they are collecting the PUI information for the persons to be swabbed. We have a walk-in line and a drive-in line. With the walk-in line, one of the nurses in PPE goes up to collect the forms, the information from the individual to be swabbed, and then they come into this clean area, this dirty area, to make sure that they get all the necessary information for the lab before the swab takes place. Next slide, please. This is the outreach we had in one of the Chuk communities on the island. We actually went to an area where we had a lot of Chukis. We discussed with them, and then they were able to allow us swab their community members. Next slide, please. So this is a family waiting to be swabbed. Go ahead.
Chima, how many people were swabbed that day? How fast can you go?
Yeah, so on the average, we do at least 200, or between 150 and 200 for all the community outreaches. But recently, we've started ramping up to 300 and 400.
Chima, I see that the community is wearing masks as well. Did you give those out, or did they come with the masks?
A lot of them come with the mask. I think the use of mask is very widespread on the island for people who really want to use them. We're seeing people who really are not using masks, but I think there are more people using the face mask than people not using it.
So folks have both the N95 mask and the shield on. That's correct?
Yes, so these are the ones with the N95 and the shields are the ones making direct contact with the individuals to be swabbed. So those ones are dressed in complete PPEs.
I also noticed that some have an N95 and some have a different respirator on. You can see the pink one there. Can you describe that, please?
So the pink one is one of the new ones that was issued to the department. A lot of the nurses couldn't fit with the regular N95, so they started using the more advanced mask that was issued to us.
One of the issues, Chima, that we've heard across the region is that the FEMA delivered N95s, and there were a lot of them. Most islands have 20,000 or more in their stocks, are mostly size large or all size large. Is that also true on Guam?
Doc, I don't have that details, but what really helped us was we had a lot of supply from the TB program and some other and the public health clinic. So during the response, we were able to pull together those resources, and we had all our nurses earlier trained to use the N95 in the clinics. So we had stock that were for those particular nurses. But for the new nurses that got on board during the outbreak, we found out that a lot of them could actually fit the mask we had. So we didn't really have that problem of sizing.
Chima, did you do any fit testing or any documentation of a good fit formal or informal, for your nurses?
Yes, Doc, like this morning by 1 o'clock, I actually have a fit testing scheduled for the nurses at the airport, at the point of entry, and also the nurses supporting the isolation facilities. So what we did regularly was we had we initially trained 30 people to fit test. So we had a collaboration with the company that manufactures the mask, and they trained 30 people from public health to do the fit testing. So we normally fit test anyone for the respirators, and we give them certification. So we have at least 30 people certified to do the fit testing in public health right now.
Chima, I'm going to put you on the spot because I know you're so good at your job, but I'm wondering which method are you using? I presume you're just using a covering over the head and then the bitters smell. Is that what you're using? Over?
Yes, Doc. Yeah. So what we normally do is we have the hood, and then we have the bitter and the sweet. We actually give them the FEMA assessment. The FEMA assessment form is filled and then reviewed by a medical doctor to make sure that they're fit, that they're actually healthy enough to use the N95. Then after that, we set up a team of the fit testers, considering the number of people we have on, considering the number of people we want to be fit tested on that day. We have, right now, we have at least 5 hoods that we're using at public health, and then we're using the bittersweet to test. And then we also we test them for different kinds of N95. We use the 1860s, the 1870s, and there's one other, we have like 3 types of N95 that we're using at public health. So we try to fit test all of them in case we run short of a particular N95. Those individuals will also be able to use another form of another type of N95. So after that, we give them a certification that is supposed to last for 1 year. So we have a proper documentation of all the nurses who have been fit tested, and we also make sure they watch the video for the fit testing, and then we also do the donning and doffing exercise. So it's a complete infection control training before we let them out in the field.
So would you recommend the other jurisdictions, if they don't have the testing equipment for fit testing, and most of them do not, what can they do to try to improve the quality of the fit of the PPE?
The challenge will be if you are not fit tested to use the N95, I think the risk is higher, especially dealing with a respiratory infection. So I would suggest that they use the proper fit testing before they use the N95.
Yes, and of course that fit testing is not special for COVID. That's the same fit testing they should be using anytime anyone wears an N95 respirator, right?
Yes, Doc.
So before we leave this slide, I want to ask you a couple more questions. Let's say you've swabbed this family and they leave, and the next family comes in for testing. Does anyone change gloves, masks, gowns, footwear?
Yes, so
what happens?
Mostly what we change is the gloves at this point, because we're trying to minimize the waste of N95. So we have a dedicated swabber, and we have 3 people who actually do the swab. So one is the person who does the actual swab, then we have a spotter, and then a clean nurse. So what happens is that the person who does actual swabbing will change his gloves after each swab. the spotter, if the spotter for any reason gets in contact with the swabber, then she will change her gloves. But if not, the clean nurse and the spotter don't usually change their gloves or PPEs, except there's contact with the patient.
So this person on the left who's standing there, she's or he's got a N95 and a shield on. And if they're not the person doing the test, how long will they wear that same N95 mask? All day?
So, because they're using the shield, they can use one N95 for the whole
Shift.
period. Yes, but so what happens that if you leave the dirty area, you need to doff completely before you leave the dirty area. So if you're coming back into the dirty area from the clean area, then you have to refit. You have to get a new PPEs to get into the dirty area. What we tried to do was to minimize. What we tried to do is to minimize movement within the dirty and clean areas. If you go down the slide, remember I explained. I tried to explain the lady who just had the face mask with an orange shirt behind. So we also have runners behind. No, if you go back some more, but you see it better in the next slide. One more slide back. Yes. One more slide forward, Doc. So the lady wearing the orange shirt and a regular face mask behind. So after they done here and get into the dirty area, she stands outside on the clean area to bring in supplies to them. So what happens that those people, the runners, wear the mask, the regular face mask and gloves to provide supplies when the team in the dirty area run out.
Excellent. So I noticed that you're not inside a fancy place to do this screening. You're doing it outside under a tent.
Yeah.
I cannot emphasize enough how important that is to increase the margin of safety for air handling, is to, whenever possible, do this testing, do any of these mass exercises outside. And personally, I would be really reluctant. If I had a choice, I'd be very reluctant to go inside a room to do a swab if I knew I could do it outside. Okay, keep going. So here's a drive-through, huh?
So this is a drive-through. You can see the runner on the outside of the dirty area. So his responsibility is to make sure that all supplies needed by the people in the dirty area gets to them without them leaving the dirty area. So we try to minimize contact between people in the dirty area and the clean area. So this is a drive-through testing on the island. You can notice that the people in the car are also wearing their face masks. So the protocol is, if you're swabbing the person on the driver's side, the passenger's side window should be up and the passenger should wear a face mask. And then when you move to the other side, it's the same process, because we're trying to minimize airflow within the vehicle. And at the same time, when we're done, this is actually the assessment area. What is going on here is the nurse will take information from the people in the vehicle. When she's done, she will put the package in a clear bag right in front of the windshield, and then they will drive to the next station, which is actually the swab station. If you move one slide forward. So this is the swab station. So at this point, the nurse is actually swabbing the individual in the car. Don't mind the guy behind, he's in the clean area. So this is the actual swabbing of the vehicle occupants. So if you notice, the driver's side window is up. Just the only window down is the one that the nurse is swabbing from.
And that nurse will change gloves after the next, between the front
Yes.
and the back even.
Yes.
What about her gown? Does she wear the gown the whole day?
So for the gown, because she wears the gown the whole day until she leaves that dirty area.
I noticed there's no foot coverings. You no need for that, you found?
Yeah, so for situations like this, most of them don't wear foot covers, not because first of all, we might have been short of foot covers, and the area is sanitized, and then the individuals do not come out of the vehicle. So that area is just for the nurses.
Shima, how many of these passengers in the car are sick?
So yes, yeah, it was most times is when we do the final check. That's when you know how many people in the vehicles are sick. But from the beginning, we were only testing symptomatic patients, and then we started opening up to asymptomatic patients. Like yesterday, we actually got a report that there were 4 occupants in a vehicle, and one of them tested positive, but they were all asymptomatic, but they're from the same household. So at this point, during the assessment that the nurses note who is symptomatic and asymptomatic, but I don't have that data right now to share.
No, it's very helpful. Thank you. Other questions from the other listeners, please? This is great stuff, Chima, and you're doing great with questions. Go ahead.
Questions? Doug, next slide. So the guy in the vest out there with his complete alien PPE is one of the traffic controls outside the dirty area. Next slide. Doug.
I think that's the last slide, right?
Yes, sir.
Okay. Our second speaker was particularly focused on hospital PPE. I don't have an update. Patricia, do you have an update for?
I'm here,
Sheila,
Dr.
please?
B.
Oh, fantastic. You ready to roll?
I am ready as I can be.
Fantastic. Okay, folks, now we'll move into the hospital and talk more about PPE. Do you want me to put up and push the slides, or can you handle that from where you are?
I think I can handle it. I'm going to try and handle it because I made a couple of changes.
Okay, Chima, thank you. Please stand by. I'm sure there'll be some great questions. And I'm going to give you the screen and ask you to please you go ahead and take the screen and let's roll. Right on time.
All righty. Okay, let's share the screen.
A reminder to everyone, also these slides will be available as will the recording. Go ahead.
So can you see it okay?
Yes, please click on full on the slideshow. The one at the bottom of the screen works best. Go down to the bottom of the screen and click on that little over there. Nailed it. All right, now you're full screen. Akila, thank you very much.
Thank you.
The floor is yours.
Good morning, everybody, and good evening to those of us that are here in the U.S. My name is Akila Muhammad, and I'm a nurse here in the U.S. with the Cook County Department of Public Health. So today I plan on talking about donning and doffing your PPE during COVID-19. I can't see my...
We can see it and hear you perfectly.
Well, my notes.
Uh-oh, yeah, that can be a problem. If you want to go to
So
a
hopefully
couple
this is
options,
still
you've changed the
okay.
slides too, so I can, that's fine. We can just go like this if you can see if you want to do it this way. We can see
Okay.
well enough. No worries.
Okay, thank you. So according to WHO, the latest evidence for COVID-19 virus has found that the virus is transmitted between people through close contacts and droplets, not by airborne transmission. So therefore, it is recommended that hand hygiene is performed frequently with alcohol-based hand rub if your hands are not visibly soiled. So what I took away from that is to make sure that there is nothing visibly on the hands before using an alcohol-based hand rub. If the hands are visibly soiled, soap and water are needed to cleanse the hands for at least 20 seconds. Respiratory hygiene is achieved by covering coughs and sneezes with the tissue with immediate disposal or use of the inside of a bent elbow if tissue is unavailable. Masks must always be worn by healthcare providers and patients, especially if the patient has respiratory symptoms. WHO also has what is called WHO's My 5 Moments for hand hygiene. And what this approach is saying is that you should always perform hand hygiene before touching a patient, before any clean or aseptic procedure is performed, after exposure to bodily fluid, after touching a patient, and after touching a patient's surroundings. So that's one big issue in the hospitals. Sometimes, you know, a call light goes on and a healthcare professional figure, hey, I could just run in the room and turn it off, just move the bedside table a little bit closer, or not very much touching too much. Hello, can you hear me?
Yeah, we can hear you.
Okay, because my screen went off. I don't know what's going on. I have a little technical difficulty here. So, but even entering the patient's environment, it will still require hand hygiene. So my next slide is, I want to discuss properly wearing a mask. Before applying a mask to the face, you want to ensure that hand hygiene is performed. Inspect the mask. It is important to make sure that the mask does not have any holes or tears in it. Ensure the mask is properly fitting on the face with the bottom of the mask covering the chin. Use the metal clamps to secure the mask over the bridge of the nose. Once the mask is on, it is important to avoid touching the mask, the outside of the mask, or your eyes, ears, or ears in order to prevent transmission of any virus. Once the mask is removed, it should be discarded immediately in the nearest trash receptacle and hand hygiene performed. PPE for aerosol generating procedures is a little bit different. The PPE for these procedures require airborne precautions. These procedures include tracheal intubation, CPR, bronchoscopy, and manual ventilation before intubation. When performing these procedures, airborne precautions again should be taken in addition to the standard PPEs that have already been taken, such as the eye protection, the long sleeve gowns, the gloves, and the N95 mask. So donning the PPE. The proper sequence for donning the PPE is very important to safely administer the care to the patients. The sequence, the sequence are the gown first, the mask or the respirator, the goggles or face shields, and then the gloves. This is one, donning or putting a PPE on in a particular way is very important because you want to protect yourself as well as the patients. The gown, one way of remembering the procedures, the proper way to put them on, a lot of suggestions have been to use mnemonics or acronyms. So I looked up one mnemonic online and it suggested using a getting dressed type of method. So first you put on your clothing, which you can also say the gown. You put on your lips or whatever you use for your lips, which is the mask. Your eyes, which you cover with your goggles or your face shield, and then finally your gloves. I prefer to use the first two letters and make an acronym. I like acronyms better. So one acronym I came up with was Go Make Good Glaze, G-O for gown, make, mask, good, goggles, glaze. Especially since I like to cook or bake, so it helps me to remember how the proper order for donning the PPE. Either way that you can help yourself to remember the proper way to don the PPE, it will definitely help. Or even if you have a good memory and just remember gown, mask, goggles, gloves. So doffing, appropriately doffing the PPE is also important to avoid contaminating yourself or the patient's environment. The sequence to avoid contamination with bodily fluids are the gloves first, goggles or face shield, gowns, and then a mask or respirator. The key is to remember to perform hand hygiene between each steps in order to avoid contamination with any bodily fluids or immediately after coming in contact with any bodily fluids. I put together a short video. It's on the CDC website and it depicts the proper sequence and way to not only don, but also to doff your PPE. So I just want to play that for one moment.
Is it us or is it them?
I'm sorry. I'll leave it right there.
Sound is a problem here, and when you're playing videos, you might want to stop this for a second.
Mm-hmm.
And when you're playing videos, go over to your, at the bottom of your screen, it should be anyway, over to your left, or the microphone. You see the microphone, it says mute.
Gotcha.
Then you want to click on the little caret arrow there, the little up arrow, okay?
Mm-hmm. You want me to turn it up?
I think what you should click is same as system. Let's see, or click on audio settings then. There's a setting here. Sorry, I'm not sure that was good advice. What you want to do is have the computer audio.
Is it in the section that said start video?
It may, there's always there's issues with sound when video is transmitted over Zoom, and it works great, but there's a certain setting that has to be clicked.
Okay, well, we could avoid that slide. It's okay. It just pretty much goes over. It's a video demonstration of donning and doffing.
I think that's great. And again, this is all recorded, and so the links will be there. And they can check also on the CDC website, right?
Right, correct. So
Okay.
one of the very big issues that we have and challenges that we have across the entire world is the shortage of the stockpile of PPEs. The stockpile of PPE is insufficient globally. So it's not a US problem, it's everywhere in the world is having the same issue. So this is particularly true for medical masks and respirators. And it's predicted that it will soon be true for gowns and goggles. So according to the CDC, limited reuse of the mask is the practice of using the same face mask by one healthcare provider for multiple encounters with different patients, but removing it after each encounter. So one of the things were with the N95, we have been instructed to do in a lot of healthcare facilities is to remove the mask and place it into a brown paper bag until we can reuse it. The problem with that is the possibility of contamination, because whenever you touch the outside of that mask, there's a possibility that you can contaminate your hands simply, or even the gloves that you use, your nose, your eyes, and your ears by touching the outside of the mask after handling a possible infected COVID patient or a diagnosed infected patient. As it is unknown what the potential contribution of contact transmission for SARS and COVID, care should be taken to ensure that the healthcare provider do not touch outer surfaces of the mask during the care, and that the mask removal and replacement be done in a careful and deliberate manner. If the masks are visibly soiled, damaged, or hard to breathe through, they should be discarded. If no masks are available, and it's in extreme situations, homemade masks or bandanas may be used with extreme caution. The CDC also references that if the healthcare provider is of high risk, if they have some of the risk factors such as the heart disease, diabetes, obesity, that these patients should be excluded from caring for possible COVID-19 patients if the proper PPE is not available. Considerations may be to use N95 respirators beyond the manufacturer designated shelf life for care of patients with COVID-19, tuberculosis, measles, and varicella. However, respirators beyond the manufacturer designated shelf life may not perform to the requirements for which they were certified. Masks generally expire because of their degeneration over time that may affect the quality of the seal and the fit, such as worn out elasticity of the rubber band. So, optimizing the PPE that you have is one of
Akila?
the, yes?
Can you go up to the top of the screen and click where it says view? To the right. Keep going across there. It says view. Click on that. And click on fit to window. Keep going, keep going, keep going. There you go.
Yep.
Thank you.
Okay, sorry.
No worries.
The use of PPEs can be minimized by establishing and implementing administrative controls. WHO states that administrative controls are a set of policies created for the prevention and control of transmission. These controls include but are not limited to provision of adequate training for healthcare workers, ensuring adequate patient to staff ratio, and establishing a surveillance process for acute respiratory infections potentially caused by COVID-19. The environmental and engineering controls address the infrastructures of the healthcare facility. They ensure that adequate ventilation as well as adequate environmental cleaning are conducted to prevent the spread of the virus. So here's another video, and when you're able to do so, just go on and click it, because what this video does is it shows you how to pretty much monitor the use or the burn rate of your PPEs on a day-to-day basis. It shows like a beginning balance, how many you use during that day, and what your end balance is. It pretty much can predict how fast you're going through your PPE supply so that you can make preparations for the future, and you'll know just about how long you can survive with the amount of PPE that you have. Well, that's about it for me. Do you have any questions?
Could you try to play that video and see if it works? The slide 10.
It'll work. It's
Yeah,
just we
just
won't
gonna be
have any
some
sound,
Yeah, we'll need the sound.
but this is definitely on the CDC website.
It's okay. Questions from the Pacific for either Akila or for Chima? Thank you both very much for a great presentation, so practical. I know that I'm fielding questions all the time about reuse of N95s, which is not a major issue for us yet, but it certainly will become one, I think. There are a few ways to recondition those N95s so they could be used, for example, the next day. We want to have great care before we make that decision. You don't have to run out before you start to conserve and reuse them. And the most common methods are to use a hydrogen peroxide vapor, which probably is not practical for us, or even UV light treatment, a few hours in direct UV light. And I know places like eBay have a fantastic, super bright, large UV light unit that they use to sterilize a room, particularly after a TB case has been there.
Right, and there's actually a really nice video on YouTube that you can order a UV light. It costs $100, and the box is actually homemade with the UV light and some aluminum foil actually. And the whole setup probably will cost about $150.
In addition, dry heat works. And it works quite well. So this is basically putting the N95s at low heat in the oven for a few hours. And you can get 2 or 3 reuses out of those masks when you do that. I think the first thing to go is often that little gray pad around the nose of the N95 that can crumble. And of course, anytime you see any deterioration, especially in a mask that's been being reused, it should not be worn, because a poor fitting N95 is no different than a surgical mask. And if you're around a patient and you're feeling confident that your N95 is working and it's not, and then we have a problem. I would like either Chima or Afili to tell us about if you've had many healthcare workers who have gotten sick.
Okay, so in the US, there have been approximately 150 nurses who have, nurses across the US who have died from COVID-19, from actually getting it and passing away. But there is no evidence of whether it was contracted at work or if it actually was something that happened in their home.
Serious business for sure. Chima, do you know, did any of your folks that worked outside in the field, did any of them come down with COVID-19 because of their work? Chima, you're still on mute if you're there. I know in some locations it was as high as 20% of healthcare workers ended up getting COVID. I think those numbers are probably have come down as we get smarter and as we do more of this outside and less inside the ER or in the ICU, as we cohort our staff so that the folks that have great expertise are limited. Chima, go ahead.
Doc, can you repeat the question? I couldn't get the question. I was trying to.
Of course. Of course. The question is, did you have any folks who helped you for the screenings who became a COVID patient because they were exposed and got sick because of a work exposure? Over?
No, we were very lucky. We didn't have any of our staff that was directly exposed to any of the patients get from the public health side that was infected. I don't have data about GMH. There were nurses that were infected at GMH, but they were not most of them were not nurses that were directly involved with patient care.
Yeah, I did hear that there were a couple of nurses who were ill. So thank you for that, Chima. So would you say then, do you think it's fair to say that if you are wearing your N95, you're being paying lots of attention to what you're doing, then there's no reason at this point that we have to fear providing care for these individuals as long as we're respecting the hot zone and the clean area, the dirty area, as you say. Be careful with our donning and doffing. You think that's fair to say?
Yes, Doc, but I think a lot has to be on the infection control training available to staff, and also more re-emphasizing. Because what happened was, as the infection control lead, I had a team that actually does the monitoring. If you notice what we did, we had a spotter. So the job of the spotter and the clean nurse is to make sure that the person who is actually making direct contact with the patient does not compromise themselves. So that particular process has actually helped us to reduce the chances of people being exposed when they are doing their job. And then also having pre-briefings before we get into testing, and then out briefing too. And then also consistently letting the staff to maintain appropriate distancing, using hand washing and using their regular mask when they are not out there in the field. Because what we noticed was that when a lot of them started getting very comfortable, they started becoming a little lax with their own personal yes. So when they're out of the dirty area, they tend to want to mingle, but we still had people who were on the lookout and made sure that people were still keeping safe distance. So I think a lot has to do with constant re-education of the staff, outside the job to make sure that they still protect themselves.
So you didn't have to reuse any PPE, Chima. How about you, Akila? I see we have a question from Margaret. Did your staff have to reuse PPE, Akila?
Not in my area, but there were issues surrounding some of the nurses that actually worked in the Cook County Hospital that were reusing the PPE, the masks, as well as the gowns in areas of the ICU.
Yeah, I can answer that question, Patricia. Yeah, the N95, we reuse them because, they're difficult to get, they're expensive, and as long as they're no soil, they're not broken, you can use them, but we protect them with a surgical mask on top of that. So you use the N95 and you apply a surgical mask on top to prevent the contamination of the mask with the droplets or soil. The gowns, we try not to use them, but sometimes if we have two patients in the same area back to back, we might go from one room to another and we change the gloves for sure. But we try not to use the gowns if possible. We keep the same hat that we're using, and we keep the same face shield or goggles. I bought my own goggles. And then we use a cleaning solution that we have after each patient to clean our goggles or our face sheet. And then when we go home, we keep our N95 in a paper bag. And then sometimes we keep 2 or 3 N95s and we rotate them. So we don't use them all the time. We try to use only one day and the next one the other day, the next one other day, to try to avoid a lot of contamination with them.
Okay, we have time for one more question, and then we need to hear from Dr. Chen. And this question was brought to us by Dr. Ali, which I think is a really interesting one. If there's a known accidental exposure of healthcare workers through failed PPE, so one of your staff has definitely been exposed, and what do you do for that staff member in this scenario? Now, obviously there's no prevention, there's no prophylaxis like a needle stick, but now you've got an exposure. Did they come to work the next day? Did you have them on any special observation, Akila?
No, they had to self-quarantine for 14 days post-exposure. And of
So
course,
regardless of whether they had symptoms, as soon as they were exposed and you knew they were exposed, you didn't let them come back to work for 14 days.
correct. Because one of the situations were that, you have a patient who comes in and shortly after triage, they may code, and you're performing the code, not suspecting anything initially, because it's novel. No one had enough information about it. And just because people have respiratory symptoms, it did not necessarily mean that they had COVID. So sometimes the healthcare providers were performing CPR on patients who went into cardiac arrest or respiratory arrest, and they were exposed. And that was a big situation, because not only that, the healthcare workers have to go home to their families.
Yeah, particularly if intubation is done, it's certainly or oxygen 5 liters by nasal cannula or something. There's certainly a high potential for a spread. I think we continue to have great questions in, but we're just not going to be able to get to them all. I did want to verify with Dr. Macias. For your patients, you preserved your mask, you said, by actually double masking, first with an N95, then over the top of that was a surgical mask, but the surgical mask basically was worn to protect the N95 mask. So I'm just wondering if on the next day, was there any treatment of that N95 or did you just use it straight up as if it was a brand new mask? Over.
Right. So most of us have 3 masks, 3 N95s, and then we rotate them. For instance, I personally keep the one N95 if I'm not sweating a lot. You know, I keep them and then I protect the N95, as you said, with the surgical mask. And if my N95 is not really moist with my sweat, I'll use it the next day as well, and the next day, and then I switch it over by the 3rd day with the other mask. But I don't toss the first mask. I keep it out, and I let it air, if you will, in my office. And then I repeat the same sequence with a surgical mask on top. And if that day is being very difficult because of working a lot and I start sweating, then if it's too bad, then I toss it and I request another one. But we are very careful with the N95s because we don't have that many. And we use the other ones. So as long as they're not dirty and they're not broken, we try to preserve them as brand new. So I have another doctors, some of my partners that actually keep, I don't know what they get them, but they keep like a 4 or 5 of them. And then you see them in their desk, you know, if they rotate, they say day number 1, day number 2, and day number 3.
I have one for each day. Monday mask, Tuesday mask, Wednesday mask, and I just rotate them.
That's fantastic. Great practical advice. Here's a question from Coach Rye that says, if we're out of N95s, can we dry it in the sun to disinfect it? I'm tempted to say the answer is probably that's a good idea. You'd want to take it out of rotation, but the UV from sunshine is probably fairly effective. I hear I'm from CDC, so I can't go on the record for saying that, but that's a reasonable thing to do. The next question was, what solution do you use to wipe down your goggles or your face mask?
So we use already a prepared chloride cleaning, like Shashbat, if you can tell me the name, but it's
Chlorhexidine.
Right, the hospital provides that for us. But in my presentation, I have a formula that is actually described by the WHO, how to prepare a chloride solution for cleaning utensils at home and also in surgical, that we use, that it can be prepared right at the site without having to buy any industrial presentation.
Thank you, Patricia. So your guys are going to have to wait for that answer for, I'm teasing you now, it'll be a couple weeks, but continue to log in every Friday and we'll get to that issue. I'd like to then move at this point to Dr. Chen, who's going to talk to us about his experience in Guam managing cases. So we need the clinicians to listen up here and we can benefit from his wisdom and experience in Guam. So Dr. Chen, please, the screen is ready to be shared. You can go ahead with your talk. Thanks.
Thank you, sir. Let me share. Can you hear me? Hello, can you hear me?
That looks good, Dr. Chen. Go ahead.
Good morning, everybody. Can you hear me?
Yes.
Yes.
All right. Today we're talking about the treatment for moderate COVID-19 patient. Uh, First of all, the COVID-19 the coronavirus are important pathogen in human and animal. The understanding of the COVID-19 is evolving, and the DoD and NIH has issued interim guidelines for evaluation and the management of the COVID-19. Today, we are going to review what we have learned about this COVID-19 disease and the clinical feature and the disease categories, how we assessed and evaluate the disease, how to manage it and manage the moderate COVID-19 disease, and how to reevaluate the patient and the goal of our treatment for this disease.
Dr. Chen, we can hear you. If you could speak a little bit louder or closer to the mic, that would be great. Thank you.
All right. Thank you. There are 5 categories of the COVID-19 according to the clinical feature. Asymptomatic infection is the first category, has been well documented. The precise frequency is unknown, but several studies in various settings suggest that they are common. Even the patient with asymptomatic infection might have objective finding. For example, in one study, 50% of the asymptomatic patients have have typical ground glass patch shadowing, while the other studies show that 20% of the atypical imaging abnormalities. The second one is the mild illness. The signs and symptoms include fever, cough, sore throat, malaria, headache, muscle pain, but no short of breath, no dyspnea, and abnormal imagings. The third category is moderate illness. There's evidence of lower respiratory disease by the clinical evaluation or imagings. And the O2 set usually more than 93% in the room air at sea level. The severe disease are the patient who has a respiratory rate more than 30 per minute. O2 set less or equal than 93% in room air and at the sea level. PaCO2 over FiO2 less than 300, and lung infiltrated more than 50%. Those are signs of hypoxemia. Okay, those are the signs of the mild, severe illness. The critical illness are a patient who has respiratory failure, septic shock, and or multiple organ failure. Today, we are going to focus mainly on the treatment option for a moderate disease. Any questions so far? Can you hear me?
Yes, we can hear
Hello?
you.
Okay.
Please continue.
All right. So the principle of the general principle of the management is continuum of care. Our understanding of a spectrum of COVID-19 as the management strategy continues to evolve. When possible, we favor managing all patients with suspect or confirmed COVID-19 within the outpatient setting. The outpatient management is appropriate for most patients with COVID-19. The remote management is preferred for majority of a patient. That's because remote management can prevent unnecessary person-to-person, like an in-person medical visit, including the visit to the urgent care or ER. The in-person visit require the patient to leave their house, traveling via public or private transportation. And there's potential exposure to the other people, include the other patients and healthcare worker. There's no high quality data supporting any single patient management strategy is better than the others. The treatment protocol has been developed and modified as understanding of this disease evolves. It is important to assess the patient risk in developing into severe disease. So we categorize patient as being high, moderate, or low risk for severe disease. The older age and certain chronic disease listed here has been associated with more severe disease and higher mortality with COVID-19. That include immunocompromised patient, the nursing home residents, COPD patient or severe asthma, chronic heart failure, severe obesity, kidney disease, and also smokers. The moderate risk usually is in the age of between 20 to 64 without comorbidities, or younger than 20 years old with medical conditions. We list as above. The lower risk is the patient with age less than 20 years old without underlying disease. For any patient with the suspect or confirmed COVID-19, we establish illness timeline to assess the symptoms and durations and severities. The timeline includes the first day of symptom begin and the first day of the dyspnea onset. The remote assess of the dyspnea should focus on the patient's subjective symptoms as well as objective assessment of the breathing. If the patient with COVID-19 has access to a reliable pulse oximetry at home, measure the pulse ox can be useful information. For example, if the patient have O2 cell less or equal than 93%, the oxygen, that means that they have, the oxygen is low in his body. We call the hypoxemia. The oxygen supplement is warranted. The other measurement we're going to do for those patients usually is the orthostasis. In the mild orthostatic symptoms, usually push through, you can manage those symptoms. The other symptoms could be dizziness. Okay, fall, hypotension, change in mental status, and also the observe the cyanosis. There's sometimes patient have chest pain that might suggest the patient have a coronary artery disease. So those are concerning symptoms warrant for in-person evaluation. Here's a flow chart. This is the algorithm for wellness check for our positive COVID-19 patients. We usually check the patient every 6 to 12 hours. If they develop those symptoms, I wish you can you read it okay? Because it's too small.
It's small, but we can see it, and I think this is an important place to stop, or to pause. And so you're imagining that you've got 10 or 12 patients on a ward, and you need to know how often to go down the line and see everyone and assess whether they're doing better or worse. You made sure they were seen every 6 to 12 hours. And after you adjusted something, say you had someone needed more oxygen, when would you go back and check them again?
Yes, this patient usually is just the isolation patient that is still considered outpatient, but they are COVID-19 positive. We didn't put in the hospital, that we put in the like a kind of like a dorm. I will show you some pictures later.
Right.
And we have
I think for the
medics
region,
going to that area. Yeah,
David, I think for the Pacific Islands, we also plan to do the same. I think there won't be a lot of management of known infected people at home.
yeah.
A lot of them will come to isolation units like this, where they'll get a little bit of care.
Yeah, that's more we consider like an outpatient remote care. Yeah, I will talk about the criteria when to send them to the hospital or go come in to get the in-person evaluation. Basically, that's we will measure their temperatures, measure their breathing and any cardiac symptoms we just talked about, and then decide the severity. I'll go ahead. We'll talk about that in the next couple of slides. Here's the okay, when to transport to the hospital. That we just have the question. When patient may present mild to moderate symptoms, but with a high risk of deterioration, should be admitted to isolated unit in the hospital for close monitoring. Here's the criteria for evaluation in the ER. First is the severe dyspnea, the oxygen saturation less than 90%, and also the altered mental status with symptoms of hypoperfusion or hypoxia. Those patients need to go to ER right away. And yeah, here's the our airman in the quarantine room, and the medics check them his vital sign every 6 to 12 hours, depending on his symptoms. For severe symptomatic patient, we usually check every 6 hours. For an asymptomatic patient, we just check every 12 hours. You can see their severity pretty high.
David, was there a form that you were using to document the findings during these checks?
Yes, we have every day we receive the the patient's vital sign with their symptoms. It's in a like Excel. It's yes, it's not a it's a form that but the medic will type in and the email to every providers, so we can review that and see if any patient need to get further attention. If a patient's doing okay, or then if you need like a symptomatic treatment like a cough mask, or if we need further evaluation, because our clinic can will not take this kind of patient. If they're symptomatic, severe symptomatic, we will talk about the criteria. We are sending to the Navy clinic. We call the ILI clinic to get further evaluation, like a chest X-ray, those kind of things, and lab. Okay.
Thank you.
All right. For the general management, we have the patient education in on the infection control. Emphasize that reinforce the importance of infection control and self-isolation. Provide instruction on the anticipate duration of the isolation. It's very important because the patient will thinking they are isolated. They sometimes develop psychological issues, can mix up with the symptoms, the COVID-19 symptoms. To manage the symptoms, the Tylenol usually generally prefer medication for fever, headache, and muscle pain. And other NSAIDs is acceptable for the symptoms if the Tylenol doesn't respond, if the patient doesn't respond to the Tylenol. Okay. Cough medicine. Cough if when the cough is persistent and interfere with sleeping or cause discomfort, it can be managed by the over-the-counter cough medicine such as dexamethasone or Tessalon-Pol. Patient need to rest. Cellpron also to improve the cough and dyspnea in some patients. The worsening dyspnea warrant to call the clinician for further evaluation. Since the COVID-19 symptoms can be overlapped with many common conditions such as flu, strep, CHF, COPD, it is important to consider other possible etiologies. So many of our negative patients with short breath we find out he has anxiety. That's why we have the psychiatry or psychology on board of this kind of treatment. If the patient have trouble sleeping, anxiety, we have this management available. The antiviral treatment has a limited role in managing the mild to moderate disease, only prescribed for the clinical trial in the outpatient setting. We'll talk more about that in the next slide. There's limited data available and potential toxicity concerns on the antiviral therapy. Okay. One of the drug called remdesivir is very hot medication. It is used to be the for Ebola treatment. Now they are using it as investigation antiviral agent. The FDA approved for emergency use in the severe and critical disease. In severe critical disease, there are insufficient data for the NIH panel to recommend for or against the treatment of the patient with mild to moderate disease. In general, no adjustment is needed for the usual home medications for the patient. If a patient have other disease like diabetes or hypertension, they can continue use their ARBs ACE for manage their blood pressure and diabetes. We advise patient use inhaler instead of the nebulizer for those COPD or the asthma patient to avoid the potential aerosolization of the virus. Consult the specialty for any of the immunomodulating medication. And any DVT prophylaxis is appropriate for the high-risk patient. This is for the medication management. Re-evaluation. Consult all patients with the warning sign that require re-evaluation, such as new onset of or worsening dyspnea, dizziness, change of mental status, respiratory status, especially in the COPD and asthma patient. At this point, the patient needs to call their clinic, their clinicians for re-evaluation if they have all those symptoms. Any questions so far? In summary, we talk about the clinical feature and the disease category for the COVID-19, and how to assess the patient remotely and in person, and also the management options. The goal of the management is mainly supportive management, symptomatic management. Medication for the COVID-19 in this category, the mild to moderate disease is not it's no warrant at this time. I mean the antivirus. We also talk about when to do the re-evaluation for the patient. Okay, this information from the DoD guideline and NIH treatment guideline, also from the up-to-date outpatient management. Any questions? Hello?
Oh, we're here, Dr. Chen. Thank you very much. That's an expansive review of what to do for moderate patients with moderate disease, and some of the expectations we should have for our cases that aren't so severe that they need to be in the hospital, or certainly not in the ICU, which is what we're really looking for. So thank you for that. I'd like to start us off with a question, and that is for the physician, what did you wear for PPE when you were looking after these cases?
Well, if the patient, yes, you can see the picture I just saw you. That's what we have here in our clinic. This is the picture. Okay. Um, yes, that's usually we do in our clinic. But most the patient direct contact is by the medics or the IDMTs. Okay. So most of the time we just evaluate it remotely. But if we need to go in, we just wear what they're wearing here. The goggles and the N95 and the gown.
Did you find that patients changed their status quickly, or did you feel like you, in general, could see what direction they were going?
Most of our patients have mild symptoms like a cough, like sometimes I have blood in the sputum, trouble sleeping. One two patient may have a low-grade fever. At this time, we haven't got a severe case. Have to send to the hospital or ER for further evaluation so far.
None. You haven't had to send any patients to the hospital at this point?
Yeah, from this, yeah, from here, from our clinic. Yes. Yes, there's I know there's a different, this is the military clinic, so there's a little bit different from the outside clinic.
Yeah, well, certainly you won't have some of the high comorbidities, and including those who are older with your population. Is that fair to say?
That's correct. We right now we quarantine about 35 patients. Only 3 have some comorbidities. 2 has hypertension. One have diabetes. That's what I have. Other patient are pretty
So
healthy.
you have 30 patients, you said, and one has diabetes.
Yes,
Yeah, so we'll
35
have
patients.
the islands will have a different experience, I think, with patients who are in isolation, as these are. Did you have a hard time with wraparound services, as we say, trash pickup, food delivery, laundry, providing them internet so they don't go too crazy, or security itself so people don't leave when they're not supposed to?
Yeah, we do. We're getting improved. That's for sure. Uh, yes, they are. At the beginning, they're pretty low morale because they think they got quarantines kind of got punished. Uh, they pretty have low morale, but we do have people. Their commander and their official also helping them uh, talk to bring the stuff they need definitely, and also yeah, also that's you can see from the picture the also our medics also help and make sure they are comfortable, have good enough sleep. At the beginning, the proposal is to do like a every 4 hours vital sign because they are so nervous the patient can get deteriorating quickly. So patient doesn't have enough time to sleep. Every 4 hours, they have to wake up for the vital. So they change it to every 6 hours. Or maybe this week, maybe next week we'll change it every 8 hours. As long as they stable enough, maybe, for this patient.
How did
Yeah,
the patients
security also. The
Go ahead.
security was an issue. There's a patient. There's a person. They mentioned that before. That's why we do have all the patients do the mandatory quarantine now. So no that's important because they they come from different area, from different all over the state. They are not how to say this? They're not the active duty patient, so it is kind of hard to manage it. That's why we emphasize that the leadership know about this. They try to. Yeah, go ahead.
No, I was just going to say thanks. Are there other questions from listeners at this point?
Okay.
Dr. B.
Yes, go ahead.
Yes, yes. I saw in the chat box, Dr. Jane, if that was him, made a comment on 2 mil healthcare workers in Guam tested positive. Is that a true statement or a typo?
In Guam, yes, in Guam, yes. That's the person is how to say this? Yes, they are the group of people came from the other base to help out for the the Roosevelt COVID-19 outbreak. They got test positive.
I see, I see. Thank you for clarifying that. And the other thing I want to ask, I understand that you haven't sent any patient to the hospital, but if
So
you
far,
come
no,
across,
knock on wood.
so far so good, no patient needs to go to the hospital. Because you talk in some of your slides, you say send the patient to ER if patient needs attention at the emergency department. Can you speak to what you have in plan for navigating patient from your clinic to the hospital ER, if they fall into the category that requires more intensive management? Do you have a separate emergency department just for COVID, or is it mixed with the rest of the patient at the main hospital? Just maybe if you can talk on the navigation part of your in your protocol.
I'm not quite familiar with that, but as far as I know, we have EMS here available, and yes, they have all the PPE. We transfer those people through the EMS. The patient do not go with their own private vehicle. If that happened, if a patient meet the criteria, patient need to get a further evaluation, face-to-face evaluation, we first send them through the EMS to the we call the ILI clinic in Navy Hospital, get further evaluation, and also get got the test and decide the further management.
Thank you. Thank you.
Thank you.
Okay, other questions? Well, as usual, we have gone past our allotted time. We sure appreciate the slides and work that were put together by all the speakers. And I think it's been really valuable for all of us here that are listening. Next week, we have another great session planned. So I can assure you that we'll go the whole time as well next week. The following week, we're going to be looking more closely again at the clinical management portion, including we'll start to touch on the severe cases as well. We'll have some time to talk about severe cases and the ventilation, proning, other issues there that I know have been a concern. Otherwise, I appreciate that that you folks took some time from your busy schedules and your patient care. I hope that this was worth your valuable time. And again, we'll want to be able to adjust to your individual curiosities and needs. So if you have other topics that you'd like to make sure we cover, we have a request for a TB and for COVID and pregnancy, which we'll find a speaker and we'll do that portion too. So if there's other specific topics, please let us know. With that, we'll say thank you again to our speakers, and we'll see you all next week at the same time. Bye-bye.
Thank you. Bye-bye.